Okay.
That's awesome. Yes, she.
There are 3 basic views for the skull. Okay, that's it. 3 basic views.
Why it sounds tricky already?
Well, it's tricky because of the angles, okay? But 3 basic views for the skull, and then we have special views that we'll cover at the end of the lecture. And so the basic ones is your apiaxial, also known as a town. The second one is a lateral, and the third one here is a PA. We call it a PA Caldwell if it's 15 degrees, and then we have a straight PA 0 degrees. But if it's PA 15 degrees, again, depending if we're doing an AP or PA, it's called the Caldwell. And then we have the PA axial, which is the reverse of the town. And see, they get to have their names on it. I'm so jealous. So we have a PA axial Haas, and then we have an SMV or a submental vertex. So let's begin with the AP axial. So the AP axial, what we need to get here is we need to get the mid-sagittal plane perpendicular to the image receptor. So your mid-sagittal plane is this area right here. Okay? So what you want to do is you want to go at the top of the table, adjust their head until the mid-sagittal plane is perpendicular with the image receptor. So you can't do that by just adjusting their head on the side. You have to go to the top and rotate it accordingly. Okay? Then their OML. What's OML stand for? Orbital meatal line. So the orbital meatal line is the outer canthus part of your eye. So it goes from the outer canthus, orbital meatal, and the meatus is the opening of the ear. So then this has to be perpendicular with the image receptor. Okay? Now if we can accomplish this OML perpendicularity, then we all need to do now is a 30-degree angulation towards the feet, a caudal angle of 30 degrees. 30 degrees, and that's going to be centered 2.5 inches above the glabella. 2.5 inches above the glabella. Okay. Now, this type of position is a little bit more difficult for somebody who might be elderly, or they may have neck pain or injury, because they're not going to be able to tuck their chin down like this guy right here. It's a little bit harder to do. Okay, so if they were more in a relaxed state, now the baseline, or the line that we're going to use, is the IOML, the Reed's baseline. So we're going to use the IOML, which is the lower part of your orbit. So it's going to be right underneath now, infraorbital meatal line. Okay, and we'll get that perpendicular with the image receptor. This is a little bit more comfortable to do than having to tuck your chin down and hold that position for however long it takes until you push that button. This is more a relaxed state. So if we use the IOML, we make it perpendicular. Instead of 30, we're going to do 37 degrees. 37 degrees caudal angle. And again, central ray is directed 2.5 inches above the glabella. Okay? So the purpose of this Towns method is to look at the occipital bone. We are looking at the occipital bone. We're looking at the back of the head. We're looking at the back of the head, the occipital bone. So with the steep angle, do you think the finished image is going to look a little bit distorted, elongated?
Yeah.
Because that's what we're trying to do, is we're trying to elongate the occipital bone. Okay? So again, you can look at the different methods of trying how to get that OML or IOML perpendicular with the image receptor. So again, if you're using the OML, it's 30 degrees caudal. If you're using the IOML, it's 37 degrees caudal. Okay? So remember which line that you are using, because it will define your angulation. Okay? All right. Keep on going. These are just different pictures of the same thing. All right. So so again, we're doing it for the occipital bone, and if you look at it, it looks very like an alien type image because it's elongated. So the proper position and projection the dorsum sellae should be projected right in the middle of the foramen magnum. It is a properly positioned town or apiaxial. Okay? The entire skull should be visualized without any type of ridges. Now, you're looking at the petrous ridges. These are the petrous ridges right here. They should be symmetrical.
Could you show again petrous ridges? It's not the wings, right? You should the lower, below them.
This is it right here. This is the petrous ridges right here. So this is the entire petrous portion. This is the ridge. This is the ridge, and this is the portion.
Thank you.
You're welcome. Now, if it's underangulated, so again, are you using poor angulation, or is there too much flexion, or is it too extended? If you are underangulated, the dorsum sellae is going to be above the dorsum sellae, so above the foramen magnum. So instead of it being here, it's going to be up here somewhere off the top. Okay, so that's underangulation. If we have overangulation, instead of seeing the dorsum sellae, you're going to see the arch of C1. That's why I put this picture up here. You guys don't have it on your slide, so I put this up here for your reference. So this front part is going to be projected inside the foramen magnum. Okay. So for us to assess if there's any type of rotation, this foramen magnum should be right in the middle, and they should be equidistant on either side of the skull, right dab in the middle. Okay. So here we have the occipital bone, you have the sagittal suture, then you have the lambdoidal here. What is this area right here? What do we got going on here? It's a what? Mastoid air cells. So these are the mastoid air cells here of the occipital bone. Okay, mastoid air cells. Okay. Okay, any questions about the apiaxial town? It's to image the occipital bone. Skull x-rays are easy. They're a piece of cake. It's when we get to the facial bones the next couple of weeks, that's where it gets hard. This is a piece of cake. The lateral skull. So by the way, what size film should be, what size image receptor should we use?
10 by 12.
10 by 12. Yeah, so small. Collimate to an area of 10 by 12, guys. So 10 by 12 is all you need. What type of instructions are we going to give them? Hold still. Hold still, don't move.
Don't smile.
And
Don't laugh.
breathe. Okay? Because when you're breathing, your shoulders move, which may cause your head to move. Okay? So hold still, don't move, don't breathe. All right. Now we have the lateral skull. The lateral skull, it can be right lateral, it can be left lateral. You need to find out where the pain is. Is it on the right side or is it on the left side? If it's on both sides, then choose a side. Okay? But you put the part of interest, the part of injury, closest to the image receptor.
So if it's on both sides, you say choose the side. We don't do both sides?
No, you're going to do bilateral. The doctor may order bilateral. So the question was, if there's pain on both sides, you just do one side. Well, the doctor will probably tell you just do one side, which is usually the left, or they'll tell you to do both sides. So you do bilateral. Okay. All right. So here we have the mid-sagittal plane. This mid-sagittal plane needs to be parallel with your image receptor. Okay, this plane parallel. Your interpupillary, okay, needs to be perpendicular with the image receptor. All right? Central ray. So first of all, we're gonna open use a small cassette, small image receptor. You're gonna open it up to the size of 10 by 12, 10 by 12, and we usually do it landscape. So 10 by 12 is gonna be like this. because your head from front to back is longer, and if you do it like this, you might cut something off. So you do it landscape. Okay? 10 by 12 landscape. Center ray, 2 inches above the, what's the EAM?
External acoustic
The hole in your
mirrors.
head. That's it. So, center ray 2 inches above your ear hole, your external auditory meatus. All right? Here is an example of someone who's traumatic and they can't lay down, they can't stand up. So now you're going to do a cross table or horizontal beam. You notice here that what they're doing is they're propping the head up. Why do we prop the head up?
Because beam is divergent, it's gonna cut it
Because
off.
the beam is divergent. Okay, because the beam is divergent, if the head was rested on the table, you're going to cut off the bottom or the back of the skull. Okay, you're going to cut it off. But you guys also see something weird about this image here. Are we getting the entire skull in the image? Yes or no?
We don't get the mandible, right? The lower.
Do we care about the mandible? No. We care about the skull. So we don't care about the mandible. So if we're cutting that off, so what? Then order a mandible. Okay? Order a mandible. That's a separate study. It's not part of the skull. All right. So we prop the head up. This is, again, an example of trauma. We prop it up so we don't cut anything off. Does it look like we're cutting anything off here?
Hair.
Well, it's hair, exactly. This is just hair. All right. So what type of lateral is this? Left lateral, right lateral?
Left.
Lateral. So make sure you're using a left marker. It's a left lateral skull. Okay. I was looking over these slides and I tweaked it a little bit because there was some misinformation on that as well. Okay. I think on your image, the greater wing was pointing somewhere up here. I think so? Okay, it should be pointing to the straight line down here as the greater wing. Okay? And I forget what this was pointing to. What does your slide say?
LW.
L what?
LW.
LW? Oh, that's your wing. Okay, so take that off. Okay? And I think also over here too, there was something about a lesser wing. It should be greater wing. Okay, but anyway, so the entire skull, so let's go back over here. The entire skull should be visualized. Again, do we care about the mouth? Not really, so we want the skull on here, okay? So the cranium is seen without any type of rotation or tilt. Optimal exposure factors are appropriate. So how do we know if there's no rotation or if there's no tilt? No rotation, superimposition of the EAM. The EAM should be somewhere around here. And you should only see it as one lucency, one hole. Okay? If you see two different holes around this area, I have a picture that I'll show you guys later on. If you see two different holes there, there is rotation. We're also looking at the mandible. Okay, this is the mandible right here. This is the condyloid process. This is what forms the TMJ. Okay, if you go look back on your slides, I didn't talk about the TMJ, but there's a fossa on the temporal bone that allows for the jawbone to sit on. This is the TMJ. So the condylar process of the mandible should look like one and not two. It should have just one condylar fossa. Fossa process, mandibular fossa process. Okay. The rami is talking about the body of the jaw, and it's hard to see in this image here. Okay, but we're actually going to look at this part right here. Okay. And then the wings of the sphenoid, and then also no tilt. You have superimposition, so you only see one line here of the orbital ridge. You should only see one sella turcica with one anterior and one posterior clinoid process. Again, we're looking at the EAMs as well. Make sure that there's one hole. Okay, so that's what we look at to make sure that we have a true lateral skull. If there's rotation, if there's tilt, you're going to see two of these. You're going to see two of these. You're going to see two of these. They're not directly superimposed. Okay? And we'll go back to the lateral later on. So, oh, by the way, laterals for the parietals. Okay, so the laterals for the parietal bones. I mean, can we see frontal? Can we see occipital? Yes, we can. But they're mostly used for the parietal bones. Did you guys fix this? I think yours said lesser, right?
Yeah.
Changed that to greater. Okay. PA cranium. So, what's the purpose of this? Which bone are we looking at here?
The frontal.
What is it? The frontal bone. Okay? So we're putting the frontal bone the frontal bone as close to the image receptor as possible. Is this easy to do?
Yes.
So again, if they're able to move, do them upright so they're not laying on their face. Okay, because this is hard to do.
So it depends on the size of the nose, right?
Depends on the size of your nose. Yes, I guess. All right. So, first one here is PA 15%. It's also known as the Caldwell. Okay. So the mid-sagittal plane, again, this must be perpendicular with the image receptor. Okay. And how do I do that? Well, you're going to go to the top of the table and adjust their head accordingly so there's no rotation. Grab their head and rotate it until there's no rotation. Okay? So mid-sagittal plane has to be perpendicular with the image receptor. Okay? Now we're going to use the OML, the orbital meatal line. So again, we're looking at the edge of the eye, the outer canthus, and with the hole in the head, making it perpendicular, and we are going to do a 15-degree angulation towards the feet to exit the nasion. You guys know where the nasion is? Top part of your nose, okay? Where your nose attaches to your face at the top. That's the nasion. Where your nose attaches to the bottom, that's the canthion. So canthion on bottom, nasion on the top. There's also an optional view here, which is center ray 0 degrees, which now it exits the glabella. They are both used for different reasons. The most common projection position is the PA Caldwell. Okay. Now, if the patient can't stand up and they can't be face down, yes.
What is that 30 degrees?
It's in the next slide. I'll explain that to you later on.
Okay.
Yeah. So if they can't be prone, can we do it supine?
Yes.
AP.
Yeah.
Okay. Yes, we can. So if we do it AP, what are we going to do with our angle?
Another way.
It's going to go which way now? Okay, it's going to go cephalic. So we can do it AP. Okay. It's just the frontal bone now is at greater distance from the image receptor, so we may get some magnification. We may get some loss of detail, but we got digital imaging now, right? So that's okay. Again, you guys are spoiled. Okay, so this is what it looks like. In the PA Caldwell, you are going to see, here's the petrous portion. See the very top edge there? That is the petrous ridge. Petrous ridges. Okay? The petrous ridges should be over the lower third of the orbit. The lower third of the orbit. It fills the lower third of the orbit on a P8 Caldwell. How do we know again if we've got no rotation? So again, properly positioned PA Caldwell, petrous ridges fills the lower third. How do we evaluate for rotation? Well, it's really simple. What we're going to do here is just we're going to look at the outer margins. Here it says the orbital oblique plane. But what I want you guys to look at is the outer edge of the orbits, and they're equal on both sides. That's how we know if there is any rotation or not. We're looking at the lateral or outer margin of the orbits. This one is referring to the oblique orbital line, or the shadow of the greater wings of the sphenoid. You can look at that, but it's a lot easier if you just look at from edge to edge, edge to edge. It's just easier that way. Okay. So this is a properly positioned PA Caldwell. We're evaluating the frontal bone. Okay. So here are some differences. So here we have criteria. Okay, so here with zero degrees, what's happening to the petrous portion? Where is it? Now, at 0 degrees, the petrous portion is filling up the orbits. Okay, it fills up the orbits.
So you mean it goes to the top, like on the image?
Yeah, let me go back. Let me just go here real quick. So when you do the 0 degrees, yeah, so this is up here now. It's going to fill up the orbits. The reason why you would do this is that it puts the frontal bone in better profile. You get a true look, a true profile of the frontal bone. Well, then why can't we do that here? Because we're trying to get the petrous ridge or the portion away from the orbit, because not only are we looking at frontal bone, we're trying to look at to see if maybe there's something happening at the upper portion of the orbit. So we're looking at not just this, but this entire area right here. Okay? So there's going to be some slight distortion to the frontal bone, but not much, because we're looking at this and we're looking at these. Okay? Here, when it fills up the ridges, we see the frontal bone, but now we can't evaluate the orbits. There's no evaluation there. Okay? Now, there is that one we were talking about earlier. We have a 30-degree angulation. You can see that there's a slight distortion to the skull. So this is no longer good for this because it becomes very elongated, but it does open up the orbits very well. So this is to look at maybe some of this, but we're getting a better evaluation of the orbits in this particular angulation. Okay, let's see if there's anything else back here we need to know. All right. So here is one, a trauma patient has a neck brace on. They're not going to be able to tuck their chin. So we get the orbital meatal line perpendicular with the image receptor. So here what we're going to do is we're just going to match the central ray with the imaginary orbital meatal line for 0 degrees. Okay, so that's going to give you the same image as this. Perpendicular. When everything matches up, it's going to look just like that with this particular view and projection.
Oh, so 0 degrees stands for how we see the image, not really the angulation
Right.
of... Okay.
How you see the image, right. Okay. So AP, 0 degrees to OML. The entire skull, again, is going to be demonstrated, but it takes out any type of distortion from the frontal bone, so this is the perfect one to use. And now you have the petrous portion filling up the entire orbital margins. Now, using you guys' x-rays eyes, can you guys see the lambdoidal suture of the occipital bone? You guys see it? Okay. So this line here is the lambdoidal suture in the back, and you have your sagittal down the middle. What's this? What's going on over here? Staples of something, right? Back of the head, most likely. Okay, so how do we know if it's AP or PA? AP or PA? So I put some arrows on there for you guys to look at. You guys don't have this on your slides.
You see sinuses there
Okay.
more.
So I'm pointing to the what? I'm pointing to the orbits, right? So if you are PA face down, okay, if you're face down, the face is closest to the image receptor, what's going to happen to the orbits? Are they going to look true to size or are they going to look magnified? True. And if you're AP supine, the orbit's going to look magnified or true to size?
Magnified.
Okay, so if you look at this, the orbit is a lot bigger than this over here. But I'm not going to look at the size of it. What I'm actually going to look at is the distance from the outer lateral margin to the edge of the skull. Okay? And then look at this one from here to here. So between the two images, which is PA? Is it A or B? PA, face down, prone.
B.
Everybody agree to that? It's B. A, the orbits are magnified. But again, I'm not looking at just on magnification. I'm looking at from edge to edge. So the distance here are a lot smaller than it is over there. CSI, baby.
Piece of cake.
All right, this one?
Everything, piece of cake.
All right, so those are your basic views and projections. It's going to be Towns, PA Caldwell, and then a lateral. Okay, those are the basic views. This one here is a special view. It's known as the submental vertex. You got to be a contortionist to be able to do this. This is hard to do. So if the doctor orders you to do this, you better do it quickly. Or set up your room and position them last. But you don't position them while you're fumbling around with your equipment because they're not going to be able to hold that position for you very long. Okay, it's hard to do. All right, so simply what we're doing here is we need to, so which line are we going to use here? Which imaginary line? IOML. IOML, what's another name for IOML?
Infraorbital.
Reeds.
What?
It's called the Reeds baseline, okay? So the infraorbital is right here below, right here in the bottom, and we're going to put that perpendicular. We're going to make it parallel with the image receptor. This has to be parallel with the image receptor. So the top or the vertex of their head is up against the image receptor. That's why it's called submental, means below the chin and exiting the top of your head, the vertex. Submental vertex projection. It doesn't say that anywhere, huh? Submental vertex. Submental vertex. Enters below the chin, submental, and exits the top of your head, the vertex. So IOML is going to be parallel. IOML is parallel with the image receptor, and the central ray is going to be perpendicular to that is going to be perpendicular to the image receptor, entering 3/4 of an inch, anterior to the level of the EAM. This sounds like a lot, right? Well, here's the EAM. So it's going to say about 3/4 of an inch anterior. So it's going to be anterior to the EAM. You see that? So that's what they mean, anterior to the AM. So it's going to come around this way. You know a better way to say that, and they should have said that? Enter at the level of the gonian. The angle of the jaw. Does it look like it's entering at the angle of the jaw? Enter at the angle of the jaw. Test purposes, 3/4 of an inch anterior to the EAM. Okay? So, to accomplish that, you're not going to be able to have them stand and do this. Or could you? I think I could. Okay? But you would get a chair. Okay? You would have them sit on a chair. And now you would have them tilt their head back. But the chair that you use can't have any wheels. Did you say that? Did you say it, Gio?
Yeah.
Yeah, it can't have any wheels. Because if you're leaning back and the chair slides from underneath you, now you'll be doing more than just a skull. Okay?
Good for practice.
Now if you do them on the table, okay, you can also do it this way. What they've done is they put the patient at the edge of the table. Then they got a, looks like they got maybe like a laundry basket, the laundry thing, you know, the blue thing. I haven't been in the hospital in a long time. What do they call them now? The linen basket?
Soiled linens.
Soiled linens, okay, yeah, the basket with the top on there. And so they use that to place the cassette on top. So they literally left them hanging off the edge with the head dangling off the side. Okay. Oh, there it is. That's a better shot.
Baskets are better.
I was going to say something, never mind. I was gonna say
Baskets
something
are
funny.
better.
I might get me in trouble.
Dr. F didn't say that.
I said it. All right. So the purpose of this SMV, submental vertex projection, you guys don't have this on your slides. It is to assess the bony intertemporal bone. The bony intertemporal bone. So we are looking. So these are your petrous ridges right here. These are right here. So this is what we are looking at. Okay, so the bony intertemporal bone and also the base of the skull. What is this right here? You guys see that? Extra density right here? That white piece? What is that?
Salatorsal.
The odontoid? C1? No, is it C1 or C2? C1 is the atlas. C2 is the odontoid, right? C1 holds your skull up and allows you to do this. C2 has the odontoid in the middle that allows you to do this. You guys remember that? C1, C2. So that's the odontoid, C2. Okay? What's this area right here? Again, what are we seeing there? It's darker.
Air cells.
Those are your mastoid air cells. Here we have the petrous portion where you're going to find the organs of hearing and balance. Here, what we're looking at here is your jaw, your mandible, and then the teeth. Okay? And remember I told you that to evaluate for your sphenoid and ethmoid sinuses, it's either a lateral or, this is the other view, is the submental vertex. So here we have, this is the sphenoid, and these are the ethmoid cells right here. Sphenoid and ethmoid. But we'll talk about that in the next couple of weeks when we talk about sinuses. Okay? So, mandibular condyles is going to be slightly anterior to the petrous pyramids, the petrous portion. Okay, so here are the condyles, just right here. It's this little, it's kind of hard to see. Here. This area right here. Okay. That's what forms your TMJs, the condylar process. Okay? Can you guys see now that I've marked it, or removed the marking? Right there. It's right there. They're round in shape. So it forms your TMJs. All right, here's the other view. Remember the towns. Okay, this is just the opposite of the towns. So this is the towns back here. What's the purpose of the towns? Which bone are we evaluating? The occipital bone. So we're looking at the occipital bone. So this is the towns. So if, okay, because we're evaluating the back of the head. If they have back head injury and they're not able to lay on it, okay, then we do it prone. We'll have them face down, okay? Because the injury is the back of the head, it's hard for them to lay on the back, so we will do it prone. So it's just the opposite now. This is the Haas method. It's the reverse towns, if you want to call it that. Okay? It's the reverse. So the OML is going to be perpendicular to the image receptor. We also want to go at the top of the head, look at the mid-sagittal plane and rotate the head accordingly so that mid-sagittal plane is going to be perpendicular with the image receptor. Central ray, 25 degrees cephalad, 25 degrees cephalad. Central rays through the EAM, exiting 1.5 inches above the nasion. 1.5 inches above the nasion. Okay. So you accomplish the same thing as the towns, except here we have magnification, right? Because the back of the head, the occipital is further away from the image receptor. Have you ever heard anybody refer to the occipital as the occipit? Have you guys ever heard that before? Okay, you may hear that out in the field. I've heard it a lot when I was a tech. They refer to it as the occipit instead of occipital. Okay, so it looks just like the town. So we are looking at the occipital bone. Okay, but it's magnified. All right, we're done. Let's just look at some films real quick. Which radiograph demonstrates the one or more positioning errors? So which one is acceptable? Do you guys like, first let's say which one is acceptable, positioning wise. Do you like A or do you like B?
B.
Not technically wise, but as positioning.
Then A.
I'm gonna say B looks, yeah, technically B looks better because it's more black and white. This is a little bit washy, okay? It's a little bit washy, but let's see. Position-wise, they're both good because you've got the dorsum sellae right in the middle of the foramen magnum. You can see it right here, right in the middle of the foramen magnum.
Doesn't skull look more straight position on B than on A? It's a little like wings. Oh, I call them those ridges. They're more like tilted on A.